All right, I'm gonna go ahead and get started. So like I was saying, mostly today, the big thing is the vestibular system, but I also will hit the thalamic and hypothalamic nuclei, and then gloss over one-hit syndromes. You really don't need to know most of them. I shouldn't say that. You need to be familiar with most of them, but the ones that you really need to internalize, I'll point out. You'll be tested a lot more on something like a one-hit syndrome for block exam than you will for STEP or comp. And if you are tested on them in STEP and comp, it'll be very specific things they ask about, and it'll be under the guise of other systems usually. Um, I hate flashcards. I'm the biggest proponent of flashcards that you could possibly be. I think they're generally useless. However, basically everything here, thalamus, hypothalamus, and one-hit syndromes, you can make 25 flashcards with maybe 4 words on each side of the flashcard, and you will get every question right in the exam. So unfortunately, these are very flashcardable topics. But first, for the vestibular system, you don't need to know the specifics. For this, it's the same thing as like auditory, like just hearing in general. You don't need to know the specifics of this is the pathway that these neurons take. That you don't need to like memorize and internalize all of the ganglia and like the little minutia there. But what you do need to do is have a general understanding of how the whole thing works. Because a lot of times, especially on the comp and step, they will ask you more conceptual questions than specific detail questions. So don't spend a whole bunch of time memorizing all this stuff, but understand the exam that you use to test the system and understand conceptually how it all works. All right, so just really quickly, I'm not going to get super into the weeds here, but for the stereocilia, they're very, 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 the mechanical sensory cells in the vestibular calculator system are, they're basically the same hair cells throughout. So more or less on like a microscopic level. But instead of being pushed down by the organ of corti, the ones in the utricle and the saccula, they are displaced by the movement of either fluid or they mentioned today the otolith. And when this, depending on which direction the hair cells are displaced in, depends on whether those hyperpolarize or depolarize, right? So if you depolarize the hair cell, it's like triggering an action potential. You see an increase in frequency of firing. And if they go in the other direction, the cell hyperpolarizes and you see a decrease in nerve impulse. This is definitely, a lot of times, if they're asking you anything about these, this is what they're going to ask you, is they'll mention a stimulus and they will be looking for, does this increase or decrease the nerve firing? It's like the carotid and sinus and aortic sinus baroreceptors, right? You need to know what those do, but every single time they ask you a question about them, the answer they're looking for is either increased or decreased firing of baroreceptors, right? The other thing to note, and this is something that would I don't want to say like it was confusing to me, but it's just kind of something that's weird, and I have seen literally a single question about it. So these channels that are open are calcium or potassium channels. They're actually located at the tips of the stereocilia. They're not at the base. I know that might sound really dumb, but I literally saw a question and the answer was ion channels at the tip of the stereocilia. And I was like, wow, that's a really weird fact and thing that I didn't think you would really need to know. All right, so you have two components to the vestibular system. Essentially, you have the otolithic mini organs, organ breakdowns. I don't know how you want to call it. But that is your utricle and your saccula. These ones are the hair cells that are stimulated by the otolith, which are like these crystals dragging across the hair cells. So these are responsible for linear movements. This is responsible for your up and your down, your horizontal. It's like this is like your horizontal and your vertical. So if you were kind of like thinking about it, it would be like your X and Y axis, right? The utricle is responsible for the horizontal plane, and the saccula is responsible for the vertical plane. I don't think that's super high yield, to be honest with you. But just be familiar with how these work. The otolith being the main cause is a very, very big thing here, because when this otolith gets displaced, that's what causes benign positional vertigo. And that is something they ask about constantly. And then the semicircular canals, which are, you have 3 of them, basically X, Y, and Z axes, right? This is responsible for your angular motion. So when I like turn my head, and these are what more or less is really what's responsible for the reflex arcs that cause nystagmus. So with the otolithic organs, because there's like a gel, like it's not quite like Jello, right? But I don't know. It's probably the consistency of like ultrasound jelly. The otoconia, which is like what they refer to, like right, like a bunch of little otoliths. They add weight and they will pull down on that gel. They don't displace. They don't come dislodged. When they get dislodged, that's when you get benign positional vertigo. But they add weight and they pull the gel down, which pulls the hair cells down, right? So and this is because these are directional. When you have disflection towards the kinocilia, which is like the big one in the back, right? It's going to increase firing, right? So you see a bigger discharge rate of the nerve cells. And when you lean your head forward, now it's causing a deflection away from the kinocilia. Again, this isn't super important that you know with like which direction. At least I've never seen a question on it. But it is important that you understand that it is the fact that it's kind of dragging them in one direction, and the direction that it drags them either increases or decreases the firing rate of the these first order neurons that then get sent down to the brain, right? And it is this constant deflection or increase that they'll sometimes conceptually ask you about in questions. The other thing is, this is kind of like a buzzword. I've had a lot of like when we had tutors, I've had a lot of people say like, "Oh, you need to know what this is." I've never seen a question on this either, but the line that is kind of drawn down the middle of these organs, that changes which way the cells are facing, is called the striola. Maybe just something to keep in mind. So then when you have the in the semicircular canals, right? So now you're back to this is your angular motion, right? So like rotational movement, right? This is all acceleration. So whereas this measures static positioning, the otolith, the endolymph, which is in your semicircular canals, is only responsible for acceleration, right? And it's important to conceptualize how this happens. So you have, I think, I'm sure Dr. Colella showed you like the hula hoop, right? But if you think about it, right? If you think about like, the best example I can give is if you have eye floaters, right? And you flick your eye, it takes a second for them to catch up, right? Because your eye moves and then the fluid hasn't quite started to move yet. And then the fluid will move and then it will displace the floaters in your eye, right? So when you turn your head really quickly, and we're just going to talk about like the horizontal semicircular canal right now because it's just easier. If I turn my head to the left really quickly, the semicircular canals move on either side of my head in opposite directions, essentially from like their own perspective, right? And it takes a second for the fluid to also start moving with the semicircular canal. So you get this initial deflection in the opposite direction of your rotating, because essentially this cupula, which is where the hair cells are that actually gets displaced and detects this motion, is dragging through the fluid as the fluid gets up to speed. Then about halfway through my rotation, now the fluid and my ear are rotating at the same speed. So now it's as if there's no deflection. And then when I stop my head moving, the fluid keeps going, right? Because it has inertia behind it. And now it continues to displace the cupula in the same direction as the rotation, right? And the only reason why I make a point to like sit here and like drag through this is because you need to understand that with the otolithic organs, you get this static increase or decrease in the firing rate of neurons. But with the semicircular canals, these neurons, you see this initial spike, which then tapers off, and then another like mirrored spike, right? So it's like it's biphasic, right? This I have absolutely seen a question on. Aside from that, you don't really need to know too much of this, but you need to be able to conceptualize this and understand why this happens, because this is something they could ask you about. And then again, endolymph is for the semicircular canals, and the otolith is what's responsible in the saccula and the utricle. Right, so this is the same thing I just said, except now it's kind of like drawn out more so that you can actually kind of see. And the thing that you will usually get tested on in this is the caloric test or the doll's eye test, which I'll go through, but it's important that you understand this picture right here so that it's easy for you to understand the caloric test. If you understand this picture, understanding the caloric test should be very easy, right? So just going through the motion again, head turns to the left, endolymph initially flows to the right, cupula displaces to the right, hair bundles displaced to the right, right? Because I'm turning my head really quickly, and the fluid doesn't want to move, right? You think like you start dragging your hand through the water, right? It takes a second to displace the water. And as the coupler is being drugged through the endolymph, it's being deflected in the opposite direction that you're turning your head, essentially, right? So if I turn my head to the left, the hair cells in the left canal are going to hyperpolarize because they're being dragged this way. And the hair cells in the right side are going to depolarize. I'm sorry, hyperpolarize, right? So you're going to see these are going to be stimulated. These are going to be inhibited. You're going to see an increase in firing of the afferent nerve fibers here. You're going to see a decrease in firing in the afferent nerve fibers here. And now the way that this is drawn, I mean, you can imagine that it's just like one big circle. It's not. These aren't connected, obviously, right? This is the left side of the head. This is the right side of the head. But you can really just think of it as if they are, to be completely honest with you, because they'll always be going in opposite directions. The fluid will always be, if you turn your head to the left, it will be as if the fluid was flowing clockwise, right? No matter which side you're on. And if you turn your head to the right, it will be as if the fluid was flowing counterclockwise. Does everybody understand this? Because if you understand this, you understand really the whole vestibular system. I'm going to take that as a yes. And when we get to the caloric testing, if there's any confusion, please do not hesitate to ask questions. All right, so nystagmus. So our brains are not capable, well, that's not true. If our eyes are focused, if you don't consciously unfocus your eyes and let everything go fuzzy, your brain will not let you just like look dead straight ahead as you like turn your head. You don't realize you're doing this, but your brain is constantly picking a new point of reference and moving your eyes to it, right? In a normal person, it's really smooth. You don't really notice it's happening, but your brain always wants to be looking at something. It doesn't matter what it is. It wants to be looking at a point in space. So if I'm looking at a point in space and I rapidly turn my head, my brain attempts to keep my eyes fixated on that point. So if I turn my head to the left, my brain is going to try to push my eyes to the right, right? And this is how you have nystagmus, right? Because as I turn my head to the left, my brain pushes my eyes to the right so that I don't get motion sick, essentially. And then it tries to correct based on where my head is facing, right? So the nystagmus moves technically in the same direction that you rotate your head because it's named for the fast component, right? So the slow component is what keeps my eyes fixed at a point in space. And the fast component is what puts my eyes back to where they're kind of level with my head, right? That's the ticking. Now, the way that your brain does this is by detecting whether you have an increased firing on one side or decreased firing on the other side, right? But this is relative. So when both sides are working perfectly fine, right? So if we want to say that this is 20 impulses per second and this is 5 impulses per second, because this is down and this is up, and we'll say that a baseline is 10, right? Your brain believes, because you can see the fluid is flowing counterclockwise, that you are turning your head to the right. Because you are turning your head to the right, right? So your brain says, oh, I'm turning my head to the right. However, if you were to knock out one of the semicircular canals, now your brain detects the difference from baseline, which is 10 impulses, to 0, and it believes that you are still turning your head to the right, even when you're stationary. So you will get this reflex. And this is how you get the nystagmus, right? Because like your brain will think you're turning your head to the right. It will try to correct for that by turning your eyes to the left. And then the cognitive part of your brain, where the subconscious part of your brain will say that your vision is moving and it's not looking at what I want it to be, and it will correct back, right? Quickly. And that is the actual nystagmus. That is the pathological nystagmus, right? So just to run through this again, in a normal condition, if I rapidly turn my head to the right, the endolymph in my semicircular canals will be flowing in a counterclockwise direction. Therefore, on my right side, I will have increased firing. On my left side, I will have decreased firing, and my brain knows that in order to keep my eyes fixated on a point in space, it needs to move them in the opposite direction that the head is turning. Now, when I have a pathology and I lose one of the ear canals, my brain detects the difference between baseline and no signal as if it was being increased and decreased, because it's checking for the difference, not the total. It's checking to see what the difference between the two of them is. So it's going to believe that my head is turning to the right. It is going to attempt to compensate for this by moving my eyes to the left, and then that is the reflex part, and then the processing part of my brain is going to say, wait, I'm not looking at what I want to be looking at, and it's going to saccade back to the right, which is a rightward nystagmus, because it's named after the correction, not the slow keeping your eyes fixed in space, the flicking. Very important. And one of the things I should have put the caloric test first, because the caloric test tests this. The Dow's eyes test, or the assessment of this reflex, is really just to check in an unconscious patient if the midbrain, if the brainstem is intact. So basically, like I said, if you take an unconscious person, you open their eyes, right, and you turn their head to the right, their eyes should not just go with the head, because the brain should detect the movement of the otolymph and attempt to keep the eyes fixed forward still, even though the head's being jerked to the right. If that happens, and then you'll see they'll like slowly drift back to the right to catch up with the rest of the face, right? Because like now they're just going back to neutral positioning. That means that the patient has an intact brainstem. If their eyes just follow their head immediately and they don't keep looking at you creepily, then you know that their brainstem's destroyed and this whole reflex arc is dead. In some, you guys haven't really learned about it yet, but like medial, I don't think you've learned about it yet, at least. And the medial longitudinal folliculus, fasciculus, which is something that is tested on kind of a lot. If you have damage to one of those, only one of the eyes will move. But we'll revisit that when you guys go over MLF symptoms. All right, so caloric testing. So now, there's a lot of words on this slide, but I'm just going to make it really easy. I'm just going to make it super simple. Heat stimulates things. Cold inhibits things, right? This is always true, right? You increase temperature, you increase dynamics of whatever you're talking about, any system you're talking about, basically throughout science. So whichever ear you put the hot water in, right? Because they're going to put hot water in one ear and cold water in the other, or they're just going to put cold water in one ear or just hot water in one ear. Whatever ear you put the hot water in, you're going to have an increase in firing of those neurons. They're getting excited, they're getting warmed, amped up, right? Whichever ear you put the cold water in, you're going to have an inhibition of those neurons. So your brain detects this as motion, because again, it doesn't have anything to do with the actual rate at which these are firing. It has to do with the difference between which the two sides are firing. So the way that I usually remember this is like, I remember the direction of the slow phase. Because if somebody hits me in the side of the face with cold water, I'm just gonna kind of like give them the side eye, right? Like, the hell is that? And then but if you understand in the beginning, right? Like I said, where an increase in firing versus a decrease in firing, right? You increase in firing on the right side, the brain thinks I'm turning my head to the left, right? There's also just a mnemonic for this. Cows, cold opposite, warm same, right? This is describing the saccade, which means this is describing the direction of the nystagmus. So if you had cold water in the left ear, you know that you're going to have a nystagmus to the right. If you add warm water to the left ear, you're going to have a nystagmus to the left. That's caloric testing. You will almost certainly have a question on this. Does everybody understand this? I need at least 2 of you to tell me you understand this. Excellent. Excellent. So now when you take an unconscious patient, the fast portion, or the saccade, that actually causes like the real nystagmus, that only happens because we are seeing our eyes moving when they're not supposed to, and our brain's trying to compensate for it, right? So if we're unconscious, there is no saccade. You will still get the slow drift, but you will not get the saccade. So if I'm talking to you now fully awake and you put water in my left ear, cold water in my left ear, my eyes are going to slowly drift towards my left ear. I'm going to look to the left, and then they're going to rapidly correct back to y'all on the screen. I will have an cold opposite. I will have left ear cold water. I will have a rightward nystagmus. But if you knock me out and hold my eyes open and do the same thing, my eyes will still drift to the left, but they will not saccade back. There will be no nystagmus. My eyes will drift, but I will not have the correcting nystagmus. And this is because I'm not receiving any visual processing in my brain to induce that reflex arc. If you have a lower brainstem lesion, or really any brainstem lesion, and you put water in the ears, nothing will happen because this whole vestibular arc is knocked out. So a lot of times, with how these questions are worded, is they will talk about, basically they'll say they put cold water in the left ear of an unconscious patient, and what would you expect to see in like in a patient that was like in surgery under anesthesia, but like they're not, would basically tell you they're not in a coma, right? They're telling you there's no damage. This person is in a physiological state. What will happen if you put cold water in one ear or warm water in one ear? That is usually how these questions are worded. And if the patient is in a coma and their brainstem is damaged, then you will have nothing, no motion at all. Okay, now basically the next 33 slides, well, that's not fair because a lot of these are questions. The rest of these slides you could do in a Quizlet. I'm being so honest. You do not need to know any of this in great detail. Do not waste time learning a whole bunch about this. Just learn the high points and you will be 100% A-okay. You literally just know what each nucleus does. And at the end of this, I have like a little table that just makes it way easier for you, right? But we're just going to go through this. If you need, because you need to know where the nuclei are, unfortunately. I have gotten questions where it literally shows basically a picture just like this with a bunch of arrows, and it will just say patient lost this. Where is the lesion, or what is damaged? So unfortunately, you do need to know where these are. And it's more annoying with the hypothalamic nuclei because no picture puts them all in the exact same spot. But it's way, way, way more important that you know just what these do, right? So in the posterior portion, right, you have the medial and lateral geniculate nuclei, right? The medials are responsible for sound. The laterals are responsible for optics, right? Optic processing. The way that I remember this is like everything else in the brain, the processing center is about as far away from the thing as possible, right? So the ears are further out on the head. Therefore, the opposite as you can go would be the medial side, right? If the ears lateral, that's just how I remember this. It's not super important, but it's important you remember it. But whatever tool you use, that's what I use. You do not need to know this. You do not need to know the areas. I've never seen a question on any exam that asked about which area. You just don't. I'm sorry. Like I know that. I'm sorry if anybody spent time committing those to memory. So then you have the VPM and the VPL. This is pain, right? So this is your this is where the spinothalamic tracts terminate. M is the face. M for mouth. L is the rest of the body. L for limbs. That's how I remember it. You don't need to know anything other than which one does what, except for this, thalamic pain syndrome. So basically, if you destroy this arc at all, or not arc, but if you destroy this pathway at all or damage this, there's two things that can happen. Either it gets confused and you hurt suddenly for no reason without any stimulus at all, or it becomes really sensitive and you hurt all of the time disproportionately. Then the other option is if you cut off the signal, eventually this will increase in stimulability. So I guess really decreases the triggering threshold, right? And then when you start to heal, this will be hyperactive, and then you'll have too much pain. Thalamic pain, it'll be really obvious in the stem. It'll talk about someone who had a stroke, and then they'll have like pain in their arm, whatever limb they lost like function in. They'll tons of pain in the same arm as it heals. And the answer is just thalamic pain syndrome. The anterior and lateral nuclei, these are the ventral anterior and lateral nuclei. These are they take input from the basal ganglia. Ataxia, basal ganglia, cerebellar input. They're never going to ask you to distinguish between the two of these. It's just coordination and planning of movement. And then here I put this in. This is what I was talking about. You honestly, if you just made a flashcard of the names of all of them, and just the first and last column, you'd be fine. You could answer pretty much any question they ever ask you. It's usually patient loses this sense. Where's the lesion? A lot of times they'll ask about these the most, and it's always distinguishing between the two. Do you know that the VPL is the body and the VPM is the face? Do you know that the MGM is the eye or ears, and LGN is the eyes? That is usually what they're asking about. Motor nuclei, just know ventro something that's not posterior, right? Not the ventral posterior, but ventral everything else is gait. Gait and planning of movement, and you'll be able to answer any question they ask you about it. Know what these do, but they don't ask questions about these. So then you have the there's a lot of topics that Dr. Colell does a very good job explaining that are very interesting, but because we use NBME exams, the questions just don't exist for them. So an example of that is knowing like the higher order. I don't think I have a slide on it. Yeah, I don't have a slide on it, but you have the higher order of processing. Be generally familiar with that. And then another thing, which if there is a question that exists, I guarantee he'll ask it because it's interesting. Our thalamic reticular activating system is responsible for basically picking what draws our attention. So when you catch something out of the corner of your eye that you think is a snake, and all of a sudden you can't hear anything, and now you're focused and you turn your eyes and your vision's fixed, and then you go back to what you're doing, it's because your thalamic reticular activating system took over, and the neurons responsible for processing visual stimuli triggered some memory, which then caused a feedback loop, which caused them to increase firing to the point where they start sending little bursts. Instead of sending tonic signals like they usually do, they started sending bursts, and this tells your brain to focus on that stimuli specifically. Another example might be, you touch something really hot and someone's talking to you, right? You're not going to hear any words they're saying until you pull your hand off and look and figure out what just happened, right? It's because this system completely takes over your brain to draw attention to particularly noxious or fear-invoking stimuli. But if you get asked a question on this, it will be about the fact that it uses bursts to do this. There's also people with ADHD. They don't really talk about it here, but it's also like heavily speculated. There's been a bunch of research on it that you have your brain has a problem doing this, and this system will sometimes activate, not fully, but in like a weird way, which is why you kind of squirrel, right? I don't know how else to explain it, but why people sometimes squirrel. Hypothalamic nuclei, they asked a bunch of questions about this. It's almost always distinguishing between anorexia and hyperphagia, or hyperthermia and picocoilothermic or the other one, inability to regulate body temperature. This again, you can just flashcard these if you want. This is the nucleus. This is what it does. It's here. This is it. It's not worth going through and giving you guys. I'll hit on like the ones that are important, but I like this slide. This isn't the best slide as far as like details goes, but I like it because it shows its orientation in the, I forget what that's called, but above the pituitary. You will also get pictures of this, and they will ask you to point to the one that's messed up. So real quick, I don't think you need to know anything about the hypothalamus that isn't on this slide. Well, as far as like the hypothalamic nuclei, obviously you have to know all the endo stuff, but so these are the ones they like to ask about a lot, because they'll talk about a patient, they'll talk about damage to it, and then they'll want you to know, is the patient going to be anorexic, or are they going to become obese? or a patient will be obese and they'll want you to know that it's ventral medial versus lateral. Leptin is a big deal, and I'll talk about it a little bit. They also like to ask a lot of questions on this. So leptin stimulates the ventral medial nuclei. Ghrelin stimulates the lateral nuclei. Leptin also inhibits the lateral nuclei, which is just important to know. And then you have your cooling centers, right? Heat dissipation and heat conservation, anterior, posterior. They ask about this a lot. I would say they probably ask about this. If out of 10 questions, I would say 5 of them are about this, 4 of them are about this, and 1 of them is about diabetes insipidus. Mammillary bodies, I don't really count that as a hypothalamic thing because you're always getting this in the setting of an alcoholic who has a thymine deficiency, beriberi syndrome. Arcuate nucleus produces prolactin. It reduces all the releasing hormones, but prolactin's the big one. So you'll end up with this amenorrhea or galactorrhea if you have over or under production, like a tumor here or a lesion here or something. And then you have your preoptic nucleus. This is the sexual orientation nuclei, but it is responsible for GnRH release. They don't ask questions about this basically ever, but in theory, if you have a problem here, you'll lead to you won't develop sexually at all. And then, which is just like your it'll be like an androgen, it'll look like androgen sensitivity syndrome or something. If they're going to ask you a question about this, they're going to do it in the repro section. They're not going to do it here. And then this is a big one, the periventricular and supraoptic nuclei, diabetes insipidus, damage to supraoptic nucleus, no release of ADH. Literally had a question on some test, which I can't name specifically, about person gets in a car accident, they have diabetes insipidus. What is the answer choice? People are looking for usually posterior pituitary. Anterior pituitary was an answer. It was a trap. Anterior pituitary does not release ADH. Supraoptic nucleus was the answer. If they're not asking about one of these 4, they're asking about diabetes insipidus usually. And then your suprachiasmatic nuclei. This is responsible for all your circadian rhythms. It's mostly sleep. This is what is part of the pathway, the melatonin pathway. If this is damaged, you have problems with sleep. All right, so leptin. So if you have a leptin receptor deficiency, you will become obese because you'll always be hungry, and not like, oh, I haven't eaten in a while hungry, like voraciously, uncontrollably, unfathomably hungry. There is no amount of food that you could ever put in your body. You will be vomiting up excess food and still starving. So if you supplement these people with leptin, it corrects the obesity because now you're able to be satiated. However, leptin is produced by adipocytes. In here, interesting. Leptin is produced by adipocytes, so you would think that obese people would produce more leptin, therefore they would be satiated earlier. Therefore, it would be our body's feedback mechanism for making sure that we do not become damagingly obese. However, you get leptin resistance, and this is basically the same. I think of this as the same thing as insulin resistance, where the more leptin you give and the more leptin that's circulating in your body sort of stops responding to it. And it can actually make you worse. So obese people are more likely to become more obese because they start to develop leptin resistance. And this is why leptin is not a good weight loss drug. When they first discovered leptin, of course, everyone was immediately thinking about using it for weight loss. Turns out you can't do that. When you give it to somebody that developed leptin resistance, they actually gain weight. The other thing too, this is another big one, like I said, temperature regulation. They love asking about this. Anterior nucleus is responsible for getting rid of heat. So if you can't get rid of heat, you become hyperthermic. They talk about this as a parasympathetic response, whereas they talk about the heat conservation being a sympathetic response. I mean, that makes sense, right? You get worked up versus you relax, right? When studying this, assumed that they would hit really hard on this. I've never seen a question on it, but it is important to know because how do you dissipate heat? You sweat, you dilate your vessels. How do you conserve heat? Vasoconstriction, pull in all the blood from the extremities, and you shiver, right? Know this. I'd be very surprised if you don't get a question on this where it describes a patient either hypo or hyperthermic, and then you just have to pick the correct nuclei. All right. We're cruising through this, but like I said, most of these with the exception of the vestibular system, really are just flashcard facts. One-hit syndromes, if you're going to be asked about it, you're usually going to be asked about it in a different setting. You're not going to get a whole lot of questions on this stuff. You need to be familiar with very specific things within each syndrome. All right, rabies, bats. Rabies, bats, bats, rabies, bats, 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 rabies, bats. Everyone thinks of rabid animals. They think of like a dog or something. No, it's bats. Bats are a problem with rabies. So much so that if you wake up in the middle of the night and your 6-year-old has a bat in their room, you have to assume that everybody in the house has been bitten and the bat is rabid and you all have to go get your shots. I cannot express enough how much of an importance it is that bats are what actually transmit rabies. Now, beyond that, I actually meant to throw it on a slide here, but I'll just talk about it in a second. Know the facts, right? Just know the facts, know the sketchy facts. For all of these bugs, like you usually have to. Rabies affects acetylcholine receptors. It irreversibly binds to them. There's really no cure for rabies. If you don't immediately get IgG, you just die, right? But the big thing that they'll talk about is either bats is the vector for rabies. If I haven't said that enough times, they affect acetylcholine receptors. And then on histo, you'll see these Negri bodies. So a lot of times it'll describe a patient in like an autopsy. It'll explain what happened to them. It won't directly tell you that they'll have rabies, but you'll probably be able to figure it out. And it'll ask what is seen and like you expect to see on histology, and the answer is Negri bodies. These are just viral inclusion bodies that are specific to rabies. Polio. Usually, if they're asking you about polio, they're asking about one of the vaccines. So this is really more of an immuno thing. But in theory, sometimes they'll ask about it in the setting of it's always atrophy of the anterior horn, which is why you get the flaccid paralysis, right? Polio likes to live in the anterior horn. They really don't know why this is, but my speculation is that if you think about it, the anterior horn, when you think about someone with polio, right, you're usually thinking of them walking around in crutches or a wheelchair. Their arms still work usually, right? Why? The anterior horn is bigger and there's more cell bodies as you get into your lumbar and sacral regions. So I imagine that polio tends to settle in the lower part of the spinal cord because it likes anterior horn neurons for whatever reason. And that's where the most of them are. That's where the most anterior horn cell bodies are. But like I said, they'll usually ask about the vaccines. Sabin vaccine, live attenuated vaccine. You get a CD4 and a CD8 response. You get a full immune response because it is a live vaccine. If you forget that, Dr. Barbosa will be very sad. He might cry. The Salk vaccine is the inactivated vaccine. You get a weaker immune response to it. In America, or in places that polio is not endemic, we get the Salk vaccine. But if you were to travel to a place where it is endemic, they would probably give you the Sabin vaccine. Obviously, you have all this stuff about you get a better immune response for this, but technically, if you're immunocompromised and you take the vaccine, you have a very small risk of contracting polio, right? Know that polio is transmitted fecal oral. I didn't know that. I definitely got a question wrong on that. And then that's it. That's it. Most people are asymptomatic. Clostridium, both species. If you are ever asked about this, they're going to basically be asking you if you know, first of all, identifying which one it is, and then how it works. So Clostridium tetani, right? This is tetanus. So this is spastic paralysis. It degrades synaptobrevin, which prevents the release of presynaptic vesicles of neurotransmitters. Synaptobrevin releases inhibitory GABA and glycine. So the reason why you have spastic paralysis is because your body cannot release GABA or glycine and presynaptic terminals. It degrades synaptobrevin. You have to know this, and you have to know this. Botulism degrades snare proteins, which are responsible for releasing acetylcholine from vesicles. No snare proteins, no acetylcholine. You get flaccid paralysis. This is going to come up. They're going to ask you about snare proteins or honey in infants. When we think about botulism, or at least before starting medical school, I always thought bad canned goods. Nope, honey. Honey is the highest yield source of botulism on any exam you take. And it usually presents in kids. So they'll be really subtle with explaining about the kid eating honey. and like the grandma gives the kid honey or something, now has flaccid paralysis. What happened? There's botulism. Snare proteins. Tetanus, synaptobrevin, no GABA or glycine. Botulism, no snare proteins, no acetylcholine. Very important. If you get asked a question, it will be about that distinction. JC virus, definitely they like to sneak this in here. I call it viral MS. The reason is because it's basically MS. The virus infects oligodendrocytes. It also infects astrocytes, but mostly affects oligodendrocytes. You get these demyelinating lesions, right? It's basically MS. The one thing that they like to talk about is, so most people are seropositive for the JC virus. Actually, when MS research was first being done, they were developing a lot of drugs that would like basically lock the immune system out of the brain and just prevent any type of infiltration into the blood-brain barrier, because they thought that by doing that, they could basically cure MS. And it worked really well. The problem is if somebody was on any of those therapies and they got the JC virus, they just died, or at worst, or they got just basically MS, right? Because now they have this virus that is doing the same thing, right? So that's why MS treatment like fell apart in the beginning. But it's basically just viral MS. If you see a stem and it sounds a lot like MS, but it's not MS, it's probably the JC virus, not Jacob Creutzfeldt, right? No, this is not a prion disorder, JC virus. I know that was a bit of a tangent, but to diagnose this, usually they just do the CT MRI and they show the lesion. They've ruled out MS and the clinical picture correlates. The only way you can actually diagnose this officially, because like I said, most people are seropositive for the JC virus, so you can't do a spinal tap, is you have to do a biopsy. So if you get a question and it asks what the like most confirmatory test for the JC virus, or if you're doing an NBME question and they're a little more nefarious, they're going to make it sound like MS. There's going to be something in the stem that points to JC virus and that it isn't MS. And they're going to ask you what the most likely confirmatory testing will be. And they'll probably have spinal fluid analysis. They'll probably have a bunch of different things that sound like MS tests. They will for sure have CT MRI, but the answer is going to be biopsy. You have to do a biopsy of the affected area to 100% confirm it. Which means it's a post-mortem diagnosis, right? You're not going to biopsy somebody's brain who's still alive. And then Lyme disease, they mention it here. You're usually not. Late stage Lyme disease, second and third phase of Lyme disease can cause neurologic symptoms and manifestations. Technically, it can cause meningitis. Never seen a question on meningitis. Definitely seen a question on neuritis, post-Lyme disease neuritis, but I've never seen a question on Lyme disease meningitis. If they ask you a question on it, it'll be just a patient with weird neurologic symptoms in like an arm or something. And then it'll just talk about like having a history of this rash. They'll describe it. They probably won't show it to you. They'll describe it in like a really vague way. And then you'll have to put together the fact that they had Lyme disease. And then it will ask you about the organism. It'll be like a bunch of viruses, and then it'll be like a spirochete. And you're like, oh, or it'll say like the thing about like the endoflagella, right? That spirochetes are. And you'll be like, oh, virus. It's got to be a virus. It's neuritis, viral neuritis. No, it's not. It's Lyme disease. Syphilis. If they're asking you about this, in just a quick reminder, for anyone who doesn't remember from repro, starts with a painless ulcer. Then it progresses to a rash, right? This is where you can get hepatitis, meningitis, glomerulonephritis, secondary syphilis. And then it goes latent for 3 to 30 years is what they like to say, where you have basically no symptoms. And then it becomes tertiary syphilis, which is where you'll get like the manifestations like the gumma of the skin. But that's also when it starts to affect the nervous system, and when you can get when it starts to affect the heart. They used to call this syphilitic insanity back in the day, because back in the day everyone had syphilis and they didn't really treat it, right? We didn't have antibiotics forever. Napoleon, right, allegedly went nuts from syphilis. So they think, I don't know if they ever confirmed that, but that's what everybody says. But early manifestations, you'll just have like hearing loss, visual loss. And then as you get into late, you get the big cognitive developments. But the one that you guys will probably get tested on is tabes dorsalis. It'll describe the patient will basically have posterior column signs. And it will ask again, like what you should do to like check for the organism, like what would be the confirmatory test. Dark field microscopy you can use to detect spirochetes, right? So with dark field, you can detect syphilis. However, they will put this as an answer choice. This will not be the correct answer. The correct answer, confirmatory, and I meant to put it on here, and I apologize to you guys, is the VRDL test. That is how you confirm syphilis. So it'll talk about tabes dorsalis, loss of posterior cord, and then the answer will be like a VRDL test for confirmation. Another little tidbit of information: VRDL test is positive and falsely positive in hypophospholipid syndrome. So if you get a question and it sounds like someone was falsely diagnosed with syphilis, and they have like a bunch of really weird like clotting and like manifestations on their legs and just like weird stuff, right? Whatever else is associated with phospholipid syndrome. It's a false. The VRDL test was false positive, and it has nothing to do with phospholipid syndrome. Like, it's not like molecular mimicry. It just interferes with the test itself. Kind of like how, I don't know, there's a lot of supplements like folate will interfere with the TSH test um, on like a biochemical level, not in like a physiological level. But yeah, if you get asked about syphilis, it's usually tabes dorsalis. And that's it. That's all I have. I have questions for you guys, of course. But as far as running through stuff, like I said, everything today except for the vestibular system, you really don't need to go into any more detail than I talked about today. Flashcard the little charts. There's like 10 terms in each subject. You can honestly learn this all in 10 minutes before the exam if you really needed to. But you will get questions. You'll probably have 2 to 3 questions on both the hypothalamus, 2 to 3 questions on the thalamus. You probably will have 1 or 2 one-hit syndromes, but it'll be like lumped in under other categories. So I hate talking about them as like their own kind of thing. Oh, I meant to put this in a slide also. You need to know. Dynin carries things up the axon towards the cell body. Kinesin carries things down the axon towards the terminal end. That is how, when you get peripherally bitten by things and it affects you neurologically, it is transported to the axon body, up the axon by dynin. I've seen that that is a question so many times. I've seen that as a question so many times. Yeah. All right. Does anyone have any general questions before we start doing practice questions? No? Good. You're all geniuses? Excellent. Love to hear it. All right. So as always, I'll give you guys about a minute to answer each question, and then I'll flip to the next one. All right. What do we got? Yep. Suprachiasmatic nucleus. Why? Because it's responsible for circadian rhythms. Right? Sleep is a circadian rhythm. Damage the suprachiasmatic nucleus. Can't sleep. In the stem, they can either be very tired, right? Like it's not going to be it's not going to be like narcolepsy, right? Like it won't be like narcolepsy. They can ask like narcolepsy adjacent things with these. But yeah, easy peasy. All right, what are we thinking? F. Yeah. Sorry, I had to read. I forgot which question. Yep, that's correct. Lateral nucleus, when it is destroyed, you are never hungry. So you get anorexia. E. Yep. Ventral posterior thalamus, right? So this is sensory, right? So they don't have to they don't always make you distinguish between lateral and medial, right? But all right, so this shouldn't really be high yield, but they like to test on it. So what's the answer? There's two ways you can answer this. Either you remembered me talking about cranial nerves or process of elimination, right? Yep, that's correct. Olfactory. Doesn't go. Does not go to the thalamus. At least not directly, right? So just know this. They, this seems like something they shouldn't ask questions on, but they like to, so. Nobody have the answer? Yep, right. 1 day old. Mother's not vaccinated. Tightly clenched fist, right? Spastic paralysis. This is tetanus, right? Tetanus, decreased GABA and glycine release, right? Synaptobrevin. Do they have it in here? They should have it in here. Synaptobrevin, right? Tetanus, synaptobrevin, glycine, and GABA. You got an answer? What is she being injected with? Nothing? What is any ideas? Yeah, it's Botox. She's being injected with Botox, right? This is what Botox is. It's the botulinum toxin. So, what is Botox? What is botulinum? Clostridium botulinum. Yep, spore forming rod. That is correct, right? Snare proteins, snare proteins, snare proteins. Botulism, snare proteins. Botulism, acetylcholine. Snare proteins, acetylcholine. You have to associate those three words together because usually either snare proteins or acetylcholine, or I guess in this case, if it's a micro question, the characteristics will be the actual answer that you're selecting. Well, I mean, I guess this is kind of, I mean, someone can just answer this, right? Like I just, what is it? Yep. Oh, interesting. I guess I debated you guys. Hmm. This is why I hate Boss. Sorry, guys. Um, you're correct. You're correct. You gave the correct answer. This is an ambot. This is I should take this out. This is not a good question. The reason why technically, if we go back, I don't have to do this. Synaptobrevin and the snare proteins. They function together. So the big difference is for whatever reason they're in different concentrations in different types of cells, which is really what's like changes how one affects GABA and glycine release, which is the one affects acetylcholine release. Every time I see snare proteins, it's associated with acetylcholine, I guess, except for this one AMBOSS question. But it is important to note that they do work in conjunction with each other. Also, as far as you had a question about how did we know that this was botulism? So she has an overactive bladder, right? So if you have an overactive bladder, it's usually due to detressor muscle overactivity, right? So the same way that you use like Botox to reshape the face, right? So like when you do Botox in the face, what you're actually doing is you're paralyzing certain muscle groups, and then the other muscle groups can like pull more, right? Um, but you use Botox. This is just what Botox does. You have to know what Botox does to answer this question, I guess. But you should absolutely know what Botox does, because you're never going to learn it outside of right now. If you I don't think there's not like a specific pharmacology slide that you're going to get from now until you take comp that explains what botulism like Botox is. Like you just need to know that Botox is botulinum toxin, um, and it is used for muscle paralysis. So any way that we use to treat like by paralyzing a muscle, um, is Botox is usually like your go-to. But I mean, you can really like hypothetically speaking, the only other substance that you would really like know about, right, would be if you wanted to say tetanus. But the problem is she has an overactive bladder, right? There's too much detressal muscle activity, and tetanus would do the opposite, right? It would increase it. It would make it spastic, so it would make your symptoms technically worse, right? It would just squeeze up. I don't know. Does that make sense? You, but yeah, this one. So the reason why this technically is wrong, because I would agree with you that I see snare proteins, and I also thought you were correct when you said that. So ascending flaccid paralysis. This wouldn't be ascending. He just injects it, right? So this would have to stay local. So ascending paralysis would be Guillain-Barré because it starts in the legs and gets worse. Um, I do agree. I do agree that this was a really dirty thing for them to say because I swear to you, if you see snare proteins on your exam, the answer is going to be uh, botulism and acetylcholine. It is not going to be tetanus. But technically, if you destroy all of the snare proteins, I guess technically you could also get because I think that the other big thing too is the Renshaw cells, right? Like they say Renshaw cells specifically, um, which are inhibitory neurons. I don't think you need to know that. Um, this is a perfect example of a question why I tell people that AMBOSS is like a great thing to learn, use while you're studying, but I would not use AMBOSS to prepare for step one, because you'll just confuse yourself and like start doing mental gymnastics. I'm like, well, maybe it's like a weird exception that I don't really know about. But no, just something to keep in mind that synaptobrevin is technically a snare protein. But typically, when they're talking about tetanus, they will say synaptobrevin, and when they're talking about botulism, they will just say snare proteins. Yep. Yep. So this question was about botulism, right? They talked about the honey. But technically this question could have been about tetanus and the answer would have been the same, right? It just would have been, instead of acetylcholine here, it would have been GABA or glycine, right? But yeah, botulism. That's it. That's all I have for you guys. Like I said, most of the stuff today is very flashcardable, to the point where it really is just a waste of your time to try to go into like hyper super detail on a lot of it. Just generally know, be aware of the things, and then flashcard all the things that I like super pointed out. And for the vestibular system, you don't need to know any like super high detail. Just understand how it works. Understand that they're usually looking for increase or decrease of the firing of the neurons, the afferent neurons, which are like the primary neurons, leaving the vestibular system. And know that it is the difference between the two sides that your brain is detecting, not a threshold in either direction. So that when you knock one side out, the brain thinks that the other side is hyperactive and the side that's knocked out is inhibited, when in reality, the side that's knocked out is just gone, and the side that isn't knocked out is just normal. But your brain detects that gap. And then know the caloric testing and the downside testing. You will 100%, you're gonna have a question on caloric testing, and you'll probably have a question on both. But as always, if there's anything else, don't hesitate to text me on WhatsApp. I'm in all the groups. You can find me, or just shoot me an email. And I'll stick around for another 5 or 10 minutes if anyone has any questions. Of course.